Evedy repair is a high suprainguinal approach most commonly used in strangulated femoral hernia as it provides excellent exposure to peritoneal cavity and femoral canal from above. Consider this as a femoral hernia model where swelling appears lateral to pubic tubercle below the inguinal ligament. Patient is placed in supine position with affected groin slightly elevated. Consider this as a midline. A vertical incision is made 2 to 3 cm above the inguinal ligament over the lateral border of rectus abdominis muscle. Incision deepened and subcutaneous tissue opened to expose anterior rectus sheath. Anterior rectus sheath is incised vertically about 2 cm medial to linea semilunaris or near the lateral edge of rectus abdominis muscle. Rectus muscle is retracted medially to expose the posterior rectus sheath. Posterior rectus sheath or fascia transversalis is opened to enter the preperitoneal space. Inferior epigastric vessels are identified in preperitoneal plane on posterior surface of rectus muscle near the lateral edge of rectus sheath. They must be identified and preserved. Injury can cause significant bleeding. Peritoneum is retracted upwards and hernial sac is identified entering the femoral canal from above. Femoral canal is bounded laterally by femoral vein, anteriorly by inguinal ligament, medially by lacunar or gymbernated ligament, posteriorly by Cooper's ligament. If hernial sac is stuck, lacunar ligament is incised medially to widen the femoral ring. Care should be taken to avoid injury to abnormal obturator artery, which can run behind the lacunar ligament. Sac is dissected free from surrounding tissues and taken out of femoral canal. Sac is opened, content examined. Usually omentum and small bowel is seen as a content. If the contents are viable, it is reduced into the abdominal cavity. If the bowel are gangrenous, peritoneum is opened and resection and anastomosis is performed. Sac is rotated and transfixed at the neck. Excess sac is cut, hemostasis is checked and allowed to retract. The femoral canal is closed to prevent recurrence. This is key step in femoral hernia repair. Femoral ring is closed by suturing inguinal ligament anteriorly and iliopectineal ligament of Cooper posteriorly. Interrupted sutures are placed with non-absorbable suture material. Usually Prolin or ethylene is used. Alternatively, a synthetic mesh plug or patch can be placed to occlude the femoral ring. On taking the lateral bite, care should be taken to avoid injury or narrowing the femoral vein. Thus, femoral ring is closed completely from above. Posterior rectus sheath may or may not be closed. Rectus muscle is placed in its position and anterior rectus sheath is closed with non-absorbable suture material using continuous or interrupted sutures. Advantages of Evedy's repair includes it provides excellent exposure of femoral canal and allows bowel resection if strangulated. Disadvantages are more invasive than low approaches and has risk of injury to inferior epigastric vessels and corona mortis. Subcutaneous and skin closed in layers. This completes Evedy's repair of femoral hernia, and key steps includes high suprainguinal vertical incision, separation and ligation of sac, and closure of femoral ring by suturing inguinal ligament to Cooper's ligament. Thank you.